Hello, good evening, everybody. Can you hear me?
Yes, you can hear you.
Good evening, class reps.
So Dr. Bia was actually teaching. He didn't know he was logged out. So I just called him now to sign back to the meeting. So just give him a minute, please.
Dr. Bia or Dr. Labere?
Dr. Alabere, don't mind me. I was actually meant Dr. Alabere. Sorry about that. Yeah. So you will join us again.
Hello?
Hello, Prof.
Can anybody see my screen?
Yes,
we can see you.
Yes, sir.
Yes, sir. All right. So like I was saying, COVID came and disrupted international airline business. So
we are not here. We are still at the introduction. The continuation of the introduction. We were at the introduction of the continuation of the introduction.
No, we were here. We were here. Except that, I mean, I was locked out. Did you see this?
No, sir.
No, we didn't see this.
No, sir.
You were locked out.
No, sir. We did not see this.
This was where we.
Yes.
No,
Yes,
yes. This one. No. The second one.
I was just talking to myself. It's all right. I told you that international travel is full of stress.
Not this one, the next one.
It's okay. It's full of stress. And what are the sources of stress? Crowded arrival and departure halls, long waiting time for your flight, and then disruption of eating pattern because of climate change and time zones and whatever. So what does travel medicine involve? It involves pre-travel consultation, evaluation of your client. If you are a health manager in an organization, evaluation of your health client to know whether they are at risk, and then make contingency planning during travel in case they will fall ill, how they are going to take care of themselves. And then when they return, post-travel care and follow up. WHO has information about countries for travelers to tell them about the potential risk they might be exposed to so that they can know and take necessary measures. I told you the reasons why people travel. They travel for pleasure, they travel for economic benefits, for academic interests, medical treatment, and then for military and police, they go for peacekeeping and peace enforcement operations, which are political commitments within the United Nations or sub-regional organizations. And then sometimes where you are might become unsafe for you and you want to relocate. Might be unsafe because of a natural disaster, because of overpopulation, the carrying capacity of your land is being exceeded, so you can't stay, or conflicts can drive you away. Globalization, urbanization, and easy access to information. That they are looking for people who have what you have, to work in Qatar, to work in Saudi Arabia, and so on and so forth, or Canada. So these and many other factors make people engage in international travel. I have left out those illegal migrants who trek from here to South Senegal, from there to Libya, and go across to Europe by boat. They have their own wahala there, but they are not captured within the framework of this lecture. So, and I talked about when I was locked out or when you were not hearing, the scope of travel medicine, epidemiology, that talks about risk factors for diseases, and then infectious diseases that people can easily contract while on international journeys. And public health, tropical medicine, high altitude physiology, particularly for people who have hemoglobinopathies, because the higher you go, the less oxygen you have. Then travel-related obstetrics for pregnant women who might be traveling far by air. Then psychiatry, occupational medicine, environmental health, military and migration. That's the scope of travel medicine. I now talked about magnitude of international travel. Now let's not waste time starting from 2012. Let's go to 2019, because that's when so the WHO forecast was that by 2030, as of 2015, the breakdown of international travel was holidays, recreation, and leisure-related travel were 53%. Business and professional are 14%. And then visits to friends, relatives, religious visit, Hajj and pilgrimage, and medical tourism, 27%. And then 6% for unspecified. The World Tourism Organization forecast for 2030. Can you hear me?
Yes, sir.
Yes, sir.
Yes, sir.
Well, because
Yes,
I'm not to
we
mute
can hear
again,
you,
no.
sir.
We can hear you, sir.
Again, no. Because somebody muted me. So the World Tourism Organization forecasts that for 2030, there will be slight increase in this data that holidays, leisure will increase by 1%, that's 54. The businesses and professional travel increased by 1%, while medical tourism, pilgrimage, and other purposes will be 31%. However, so the WHO World Tourism Organization forecast was that in absolute terms, international tourist, sorry, in relative terms, international tourist arrival will averagely increase by 3.3% annually till 2030. And then in absolute terms, 43 million yearly between 2030 and 2010 and 2030. And then at this rate, international tourist arrival worldwide was expected to reach 1.4 billion by 2020 and 1.8 by 2030. However, this did not come to fruition because of the COVID-19 of 2019, end of 2019. Up to the last quarter, the third quarter of 2019, these predictions were okay. But when COVID came in 2019, the last quarter, then everything went down. In fact, the airline industry almost collapsed, and a lot of them had to look for lifeline to remain afloat because there were restrictions globally everywhere. So 2020, serious restrictions. It recorded 1 billion fewer international arrivals worldwide compared to what was recorded in 2019. So by 2021, the COVID restrictions were still there. So there was almost zero movement. So 2021 saw, towards the end of 2020, saw some slight improvement, but only a very subtle way with restriction. There were 1 billion fewer international tourist arrivals in 2021 compared to 2019. The same thing for 2020. Then loss of $1 trillion in total export revenue from international travel. So it, however, increased in first half of 2022 because of relaxation of some of the restrictions. It increased by 221% over the 2021 data. So now let's leave this data. Let's go to something else. As at last year, international tourism has reached 97% of pre-pandemic level. So an estimated 285 million tourists traveled internationally in the first quarter of 2024. The Middle East saw the stronger relative growth, with arrivals exceeding 33% of pre-pandemic level. And it was like that for all regions of the world. So let us look at human mobility and the spread of infectious diseases. We talked about the international health regulations because they were all about allowing free movement of people, goods, and services without restriction, and taking all necessary precautions to ensure that communicable diseases are not spread from one region to the other as a result of unrestricted travel. So human mobility and travel of disease is influenced by travels generally, whether by land, by sea, or by air. So increases in global mobility of humans, animals, and plants, as well as products, are responsible for driving infectious disease to new locations. There have been several infectious disease spreads well beyond their previously understood geographic boundaries. We talked about Ebola, we talked about COVID, we talked about SARS, we talked about MERS, talked about Zika, which is a mosquito-borne infection in South America. So we have also witnessed the emergence of spread of novel pathogens such as the Middle East influenza, which I've said. So many factors are responsible for the global spread of these diseases. And what are some of these factors? Increase any problem.
Have you carried my phone?
So what are some of these factors that are responsible for the global spread of infectious diseases? Increasing speed and reach of human mobility. If you leave Nigeria, in the next 18 hours, you can go around the entire world. The next 12 hours, you might be in Australia. Another 12 hours, you might get to east coast of US. And that is how it is. Increased volume of trade and tourism. And then changing geographic distribution of disease vectors. These are some of the factors that aid in the spread of infectious diseases globally. So human travel and migration through air is now a major driving force, pushing infectious diseases that previously were non-endemic in some settings. There are some diseases that are endemic in some settings, and they are not in other places. But somehow, the vector for such diseases might be in those places where those diseases do not exist, like yellow fever in parts of Asia, particularly the Indian subcontinent. But the non-human primates are there, monkeys, baboons, gorilla, they are there. Aedes mosquito is also there, but the virus is not there. So people can carry yellow fever from West Africa and go there, or from East Africa and go there. So each year there are increasing number of international tourists, more international refugees and migrants, greater capacity for shipping by sea, and greater international air travel passengers through by volume. So air travel is the easiest way to move from place to place, the international level. It poses a growing threat to global health security. Because the problem of COVID was people who moved from Wuhan to other parts of China, then to other parts of Asia, Europe, Africa, and America. So it's not possible for a traveler harboring an infectious agent in one location on the earth to travel virtually to any other point within 1 to 2 days globally. So infections introduced through travel may be sporadic and have little potential for further transmission, like Lassa, if it's introduced to European setting. In other situations, air travel may cause self-limiting local epidemics, such as chikungunya virus in Italy. But there are many more that can spread easily, like COVID. So vector-borne diseases like arthropod-borne diseases, viruses, present unique challenges, as these vectors, like mosquito, can be carried over land in boats, on aircraft, and may travel between any 2 points on the globe within its lifespan. In other words, from the time the larva develops into an adult until it dies, it can move around anywhere, can be transported by boat, by aircraft, by car, and so on and so forth, by rail. So such vectors have the potential to infect non-travelers in their new destination. So a traveler can come, the vehicle can bring it, the aircraft can bring it, the train can bring it in, and then they might be carrying the viruses or the parasites that will spread, go and bite people in the new location and give them the disease. So airport malaria is an example of it. Even if a vector is not infected, that vector may become endemic to a new region if there are suitable environmental conditions, and then potentially enable further future epidemics. So that is it. So vectors, introduction of vector is further facilitated by ecological factors such as climate change and urbanization because of change in temperature, humidity, rainfall, and so on and so forth. Where some vectors previously did not exist, they can now exist if they are transported there. And then they can now transmit the disease if they are in contact with those who carry the virus or the parasite. So let us look at morbidity and mortality pattern in international travel. So travelers are exposed to various health risks, leading to patterns of illness or death that differ from those in their home country. So they are susceptible to injury-related deaths if they have road crashes, air crashes, homicide. They account for a significant proportion of deaths among travelers. And these deaths are often preventable. Infectious diseases, particularly what we eat and drink, can be a source of sickness and death. Then vector-borne diseases like malaria, dengue are also very important, especially when visiting regions where these diseases are prevalent. And then you might have pre-existing chronic health conditions like diabetes, hypertension, liver or kidney problems. So the stresses of the journeys, the travel, can also exacerbate health conditions like those who have heart diseases, diabetes. So, and then mental health conditions, travel can also impact mental health with stress, with issues as anxiety and depression being common among travelers. So travelers should be aware of these risks and take appropriate precautions, such as getting vaccinated for vaccine-preventable diseases, practice safe behavior, and so on and so forth, so that they can remain healthy until they return. So let us look at data on morbidity and mortality pattern among travelers. It is recorded that 1/3 of international travelers experience travel-related illnesses. 1/3, that is 3 out of 9 travelers. About 50 to 75% of short-term travelers to the tropical region and subtropical region, they develop health problems, usually due to infections. In other words, those coming from the temperate region to the tropics or subtropics, 50 to 75% of them develop health-related problems, mostly due to infectious conditions. And then half of travelers from developed countries who stay about a month or more in developing countries get sick. Then the commonest problem encountered in international travel is travelers' diarrhea, stooling, vomiting. That's because of what you eat or what you drink. What about the mortality pattern? While the commonest cause of sickness is infectious diseases, for death, the commonest is cardiovascular problems, pre-existing health problems. They contribute to 50 to 70% of deaths. Accident and injuries, air crash, road traffic accidents, drowning in recreational waters, contribute about 25%. And then infectious diseases contribute just 2.8 to 4%. So they are the commonest cause of the sickness, but are the least cause of death, because they can easily be treated if you get the right place to get the treatment. Any questions, class? Hello? Now, what is the risk of acquiring an illness during international travel? This depends on several factors. Key amongst them is the area of the world that you are visiting and the time of visit. If you go to Europe during winter, you're likely to get flu. If you come to the tropics during the rainy season, you're likely to get vector-borne diseases. So the area of the world you visit and the time of the visit are important. And then how long you stay in that area will determine the contact you are going to have with disease-causing agents. So the longer you stay, the more likely you are to get sick. And then another one is the standard of accommodation. If you stay in a cheap hotel that hygiene and sanitary conditions are poor, you might run into health problems. And then again, your behavior during the travel is also a serious risk factor for acquiring illness. What do we mean? You can go to a new country and say, let me try this food, which is not known in your place. Let me try this drink, and so on and so forth. Or you say, this one, I come this country. Let me look for one woman from here so that I will say I have a friend in this country. That kind of thing. So your behavior during the travel can also be a source of illness. And then your activities and location of travel within the area you visited. Whether you're hanging out with people in fast food places, roadside food joints, and so on and so forth. And then finally, whatever underlying health conditions you had before you travel, stress factors can exacerbate them and make you trip. So any questions, class, with regards to risk of acquiring illness in international travel? So what are the infectious diseases of potential risk for international travelers? The commonest of them are food and waterborne diseases, diarrheal diseases, hepatitis A, enteric fever. Then vector-borne diseases like yellow fever, malaria, dengue, leishmaniasis, trypanosomiasis. Malaria, yellow fever, Zika, they are transmitted by mosquito. Dengue, leishmaniasis by sandfly, trypanosomiasis by sassafly. Then zoonotic diseases. Zoonotic diseases are diseases that are transmitted from animal to human under natural conditions. Maybe you eat them or you live with them, you play with them as pets, as the case. Lassa, plague, rabies, teniasis. That's tapeworm. Then sexually transmitted diseases are also diseases that are potential risk to travelers because you might be exposed to unhealthy sexual practices. Then blood-borne diseases, hepatitis B, C, and HIV. If you are involved in any activities that require exchange of blood or body fluid, as the case may be. Then airborne diseases like cerebrospinal meningitis, influenza, measles, mumps, and COVID. Then soil-transmitted diseases like ankylostomiasis, and then tetanus. So these are infectious diseases of potential risk for travelers. Any questions? So let us go to another aspect of today's lecture. Let's look at health requirements for international travel. We said that the international health regulations are to ensure that trade and travel are not restricted. However, in as much as people can travel as they like, we want to make necessary precautions to ensure that they don't bring in diseases or vectors to the places where such diseases do not exist. The control or containment of known risk to public health is one of the most powerful ways to improve international health. The World Organization member states adopted the international health regulations. The last revised one was 2005 to avoid the spread of infectious diseases that have epidemic potential. And by so doing, they don't want to do interference with trade and travel. So what are the diseases in focus for prevention when people are traveling? Diseases that have sufficiently high global and regional prevalence to constitute a significant risk for travelers, like yellow fever. Yellow fever is endemic in most parts of Africa, sub-Saharan Africa. And the vector is Aedes mosquito. And then it's a disease that has non-primate hosts, like monkeys, baboons, gorillas that are in the forest. So the disease is endemic in sub-Saharan Africa. So another group is diseases that have severe and life-threatening, even though the risk of exposure may be low for most travelers. Ebola is a severe life-threatening disease. The same thing with Lassa fever. So we need to take necessary precautions regarding this one among travelers. Diseases for which perceived risk may be much greater than the real risk, and which may therefore cause anxiety to travelers. If you hear that somebody who had Ebola is inside the same aircraft with you, or was in the aircraft that you landed, they're going to be very tense. Lassa fever or COVID, as the case may be. So these are diseases that perceived risk may be much greater than their real risk. And then lastly, diseases that involve public health risk due to transmission of infection to others by infected travelers. Ebola, cerebrospinal meningitis. These are the diseases in focus. This group of diseases are the ones in focus while looking at international travel. So, what are the requirements? Previously, 3 diseases were of international significance: yellow fever, plague, and cholera. Vaccination certificates to undertake international travel for these 3 diseases. However, with changing pattern and control of plague and cholera, these 2 diseases are no more health threats in most of the countries. However, those going for Hajj in Saudi Arabia will require cholera vaccination in addition to yellow fever and then cerebrospinal meningitis. Now, why do we need yellow fever vaccination in some countries where the risk of infection exists? Dr. Chukwu, you are disturbing this case. Dr. Chukwu, mute your mic. John Chukwu, mute your mic. Dr. Chukwu John, mute your mic.
He has done that, sir.
So why is yellow fever vaccine still needed? It is needed because we want to prevent the international spread of it by protecting countries from the risk of importing or spreading the disease. Like I said earlier, there are countries in Indian subcontinent. A country like India, yellow fever virus is not there. The flavivirus is not there. But the vector, Aedes mosquito, is there. The non-human primate hosts are also there. Monkeys are there. So if somebody comes in with yellow fever and that person is bitten by Aedes mosquito, they can pick the virus and start to transmit it. So countries in this category that require proof of vaccination are those where the disease may or may not occur, but where the mosquito vector and potential non-human primate hosts are present. Any importation of the virus into such countries by travelers that are infected could result in the spread of that disease, making it permanent risk in that country because the vector is there. The non-human primate hosts are also there. So such countries will need proof of vaccination before you're allowed to enter their country. The second category are those travelers who may be exposed to yellow fever infection. Maybe you are coming from where there is no yellow fever, but you are going to where yellow fever exists, coming from India to Nigeria, to Ghana, to Kenya. You will require to be protected so that when you come, you are not going to pick the disease. So the risk of yellow fever transmission depends on the presence of the virus in the country in humans, animals, or mosquitoes. The disease is frequently fatal for those who have not been vaccinated. So therefore, you need it. So how do we prepare our clients for international travel? Well, like I said, we might be senior managers, health managers in organizations where we work. And then there might be need for officials for international travel. And they might come to the clinic asking us to give them the needed advice or prepare them for international travel. So the preparation of international travel will require pre-travel assessment. Ideally, that assessment should be undertaken about 6 weeks before the time of travel, so that if there are vaccines to be taken, they would have taken them and they would have started working before you travel. So why do we need pre-travel assessment or consultation? We want to look at your documents. We want to document the places you want to go to. Which country are you going to? When are you going there? Are there stopovers? Maybe you are going to Far East. You have to go through Dubai, stay there, then go like that, stopovers like that. So documenting all the places the traveler plans to visit, including stopovers and side excursions, the time of the year for the trip, because the time of the year affects the risk of acquiring infection. Because many infectious diseases have cycles that are associated with particular season or rising ambient temperatures. So the purpose of the visit and the duration of stay, because we said that people coming from the temperate region to the subtropical and subtropical that stay longer than 1 month are likely to be sick. So we need to know how long they are going to stay. The duration of the trip, influencing the risk of acquiring a given disease. We want to know whether you are allergic to certain drugs, food, and whatever. Then we look at your vaccination history. Are you up to date with the required mandatory vaccines? Then we look at your past medical history. Do you have any health conditions for which you are supposed to be on medication? And then If you are not taking vaccines, immunizations, look whether they will need to take booster doses and then wait for adverse reactions. So each piece of this information will enable the clinician determine the risk and benefit of vaccines for that trip. Any questions, class, for pre-travel assessment or initial consultation. After that, you will be given advice while you are on the journey. Advice to international travelers how to take care of themselves while they are away. So, for pre-existing diseases, the advice is that take all your drugs along. Drugs that will last you for the duration of your stay and possibly a bit longer. Why? Because it's not like Nigeria where you just go across the counter and buy any medicine. Outside Nigeria, most countries, you require a prescription before you can buy drugs. So if you don't carry enough drugs and your drugs are finished, then you look for a clinician, go to a health facility, they give you prescription before you can buy. To avoid that, carry as much drugs as possible that will last you longer than the intended duration of stay. So if you want to stay for 1 month, better you carry drugs for 2 months. All physician instruction concerning your drugs, physical activity, diet, you should comply with. And then for immunizations, you have to be up to date with all immunization. There are routine childhood and adult vaccines that you should take. Children, or measles, mumps, and rubella. Requirements, those mandatory ones, for those going for Hajj or going for Asia, like yellow fever. You are going for Hajj, cerebral meningitis, and cholera, but you need them. Then there are other recommended vaccines to protect you: influenza, typhoid, hepatitis A, B, measles, and as the case may be. If where you are, measles is not endemic. Recently, there was measles outbreak in the US. So that is it. Any questions, class? That's for pre-existing health conditions and then for immunization. Let us look at advice with regards to food and waterborne diseases. Hand washing is one of the key ways of preventing infectious diseases. So you need to wash your hands as often and always before handling and consuming food. You need to make sure that food that has been thoroughly cooked and remains steaming hot is what you eat. In particular, you need to avoid seafood, poultry meat that is still red or where the juices are pink, or minced meat or burger that are still red, as they may contain harmful bacteria. You need to avoid foods at buffet, markets, restaurants, and street vendors if they are not kept hot or refrigerated. For fruits, you should be the one to peel the fruits that you are going to eat, if you are going to eat them raw. Any fruit that has damaged skin should be avoided because some toxic chemicals could have entered the broken skin. So, and then in some countries, water supplies are varied. Sometimes in the bathroom, the water you see is not for drinking. So you can't use such to brush. So you have to be sure of whatever water you are consuming. You are advised to take bottled water where the cap is sealed. If the cap is broken, then you don't take it. If you have doubt about the source of water, you can boil the water and drink it. And then sure that any dishes, cups, or other utensils that you are using have been washed and kept dry. In Nigeria, we have that habit that you go into a hotel, they give you a dry glass. You want to rinse it first before using to drink. Once a glass has been washed and kept dry, Desiccation is one of the things that kills germs. Desiccation, drying, kills germs. So when you try to introduce water to rinse it before you drink, you might be introducing germs. But that is how we do in this part of the world. So now, you never can tell. Even the ones that are looking okay, food they are eating, they are looking okay, drinks, you might still come down with vomiting and stooling. So you are advised to carry antimicrobial and anti-motility drugs like quinolones and loperamide, as well as oral rehydration salt in case you start vomiting or stooling, so that you can use it to rehydrate yourself. As much as possible, drink enough fluids so that you will not be dehydrated, because dehydration can turn into fluid imbalance and you run into unnecessary health challenges. Any questions with regard to food and waterborne diseases? The advice. Vivian Ralph. Vivian Ralph. Hello.
Yes.
What about vector-borne diseases? We are expected to use insect repellents if we are going to be outside at hours where, or we're going into, maybe you go for a safari. Go for a safari, and then vectors might be there, you get exposed. So those exposed part of your skin, apply insect repellents and wash them off as soon as possible after you are no longer exposed to insect bites. Permethrin-coated clothing and bed nets could provide additional protection. Permethrin is the chemical that we use to treat insecticide-treated nets. So you can commence chemoprophylaxis where necessary before embarking on journeys where the perceived risk of infection exists. So you carry specific chemoprophylaxis, like you are coming to Nigeria, you can carry anti-malaria. In case of clinical disease where possibility of getting appropriate treatment immediately is remote. Like I said, in most countries, you can't get drugs across the counter. You have to go with prescription. So that is it. This for advice against vector-borne disease. What about advice against accidents and injuries? Because accidents and injuries, after cardiovascular problems, they are the next most common cause of mortality amongst international travelers. So for accident and injuries, you need to carefully select the type of vehicle or aircraft you are taking to reduce the risk of trauma and death. For road travel, overcrowded vehicles and those that lack safety devices, they make foreign travel very risky. Night driving should be avoided, and avoid flying on unscheduled airlines or airlines that do not have a good safety record. Some years back, Nigerian airlines had very poor safety records until Kenneth Dike was, his committee went and audited the airline industry and made recommendations that made the Nigerian airliner become more safer. So you need to obtain information on regulations governing traffic and vehicle maintenance, because sometimes you might travel and want to drive by yourself. If you want to drive by yourself, then you need to know the rules of the road in that country you are visiting. You might want to hire a car and drive the stay you want, but you need to check for safety, the conditions of the tires, seat belts, spare tires, brakes, and so on and so forth. In some countries, there are informal rules of using the road, like you want to overtake. They will tell you that it's how to shine your light or blow your horn, as the case may be, before you do that. So, if you are driving, you must have a driving license. Not like Nigeria, police stop you, you say, esprit de corps. You give them money. Some countries, they cannot. They don't take bribe that we take in this country. Be particularly vigilant in a country where traffic drives in the opposite direction. There are countries where traffic drives in the opposite direction. UK, Australia, some countries like that. Avoid driving after you have taken alcohol. Then try to drive within the approved speed limits. Always wear a seatbelt. And then avoid driving in unfamiliar or unlit roads, particularly at night. Daytime, you can see the road far away. But at night, you might not know, like Nigerian roads, there might be potholes, broken down vehicles. In the night, you don't know when to drive and run into another vehicle. So two-wheelers, motorcycles, bicycles, and tricycles should be avoided because they can easily be knocked down. And then wandering animals is another thing, particularly in Nigeria. People coming to Nigeria. In the night, you'll be driving, you think that that light you are seeing is one lamp. No, maybe a cattle rearer is marching on the road with his cow and he's holding one lamp, torchlight. You think that a lot of cow might be on the road, so you might run into them and get an accident. So you have to be aware of wandering animals. And then the last one is drowning in recreational waters. Drowning and impact injuries in adults are frequently associated with consumption of alcohol. When you consume enough alcohol, it will impair your judgment and your ability to react quickly when bad situations occur. So around recreational waters, you're expected to adopt safety behavior. Use life jackets where appropriate. Pay attention to, if you're entering a boat, please look for a life jacket and wear, even if you know how to swim. Seek information from local residents regarding tides and currents, and avoid outlets in spa and swimming pools. If you are with children around any body of water, you have to supervise the children well because they are exploratory. So if you don't supervise them well, they might go and get drowned. You blame yourself. And then if you have taken alcohol, stay away from any water body. And if you are swimming or you want to be part of the beach activities, you check the depth of water carefully before diving in. And if the water is musky, then you better avoid diving into such water because there might be things that are submerged there. You dive and hit them, or people who might be there might jump on them. So these are the advice we give to travelers before they go. Any questions, class? If there's no question, we have come to the end of this lecture. So let us look for the next lecture. Hello? Does anybody see my screen?
Yes, sir, we can see it.
Yes,
What are you seeing?
Yes, sir.
Health information management.
Management system and disease surveillance.
Thank you very much.
We are
Thank you very much. This is the
Health
outline.
information management system and
No,
disease
we have passed that one now.
surveillance.
Are you not seeing my screen? This is the outline.
Yes, sir. Yes,
Yes,
sir.
we can.
Outline,
These
introduction,
are the things we're going to
and health
discuss.
information.
Introduction,
Yes.
We look at what health information
Goals
management
of
is.
health
We look at the goals, look at the sources of health data and information.
management.
Then we look at surveillance. Surveillance. Active and passive surveillance. Then we look at disease surveillance in Nigeria. And then look at the problems of health information management in the country. And then summary and suggested solutions to improve some of the health information management problems. So let us start. Now, I hear a lot of students talk about data and even call data. Data is plural of datum. Datum, D-A-T-U-M, is the singular. The plural is data. So when you are using the word data, you are talking about plural. So health information management relies on data because it's vital in the management of any organization, program, or service. Data is necessary for basic planning. Without data, you cannot plan. Whatever you do will be guesswork. So, information management is one of the building blocks of any health system. So, what is information management system? It's any system that provides data or information about the operations of an organization. In the healthcare system, we need data to monitor our patients, to monitor programs and services, to account for materials we use. So health information management is the practice of acquiring, analyzing, and protecting medical information that is vital to providing quality patient care. So it represents the body of knowledge and practice that assures the availability of health information that is needed in real time for healthcare delivery and critical health-related decision-making. You need information for healthcare delivery. Like I said, was it yesterday or so? We clerk patients. In course of caring for patients in the ward, we take vital signs. We chart the drugs we are giving, input-output chart, and so on and so forth. That information is needed to monitor the progress of the patient. The temperature chart tells us whether the fever is going down or coming up. The respiratory rate tells us how the chest is functioning. The blood pressure tells us the cardiovascular system with the pulse rate. So these things are important. Heart sounds, the murmurs, the respiratory sounds, all of them tell us, and they guide us in the management of our patients. The laboratory results, the full blood count, electrolyte and urea, renal function test, kidney function, liver function, all of them, culture results, they tell us something. So they are important. Health information is important in healthcare delivery. Also important in decision making. So health information management system is concerned with management of resources to collect, store, retrieve, interpret, and communicate health information that deals with patient's care, medical legal issues, research, planning, provision and evaluation of health services. So if you are carrying out an immunization program, outreach program, you determine the number of doses of vaccine you go with. You determine the target population. And then you go out with enough vaccines and then syringes, swabs, and whatever. Then by the time you come back, you should be able to account for what you have used and what you have not used. So let us look at the Nigerian Health Information Management System. It was established in 1989. And the purpose was to provide a tool for decision-making at all levels of government. The structure comprised the National Information System unit at the national level that coordinates the corresponding units at the state and local government level. In other words, health data is collected at the point of service delivery and then passed through the local government to the state to national level. So what are the goals of health information management system? One, to assess the state of health of the population. Can tell us mortality rate, morbidity rate, case-specific rate, and so on and so forth. It enables us to identify major health problems and to set priorities on local, state, and national level. Then it also enables us to set priorities for health interventions and actions. If there are so many problems, which of them are we going to solve if we don't have resources to solve all of them? So priority setting, health information enables us to do that. It also enables us to monitor progress towards stated goals and objectives. Any program or service will have goals and objectives. So the indicators set during the planning phase will enable us to know whether we are reaching our goals or achieving our objectives. So health environment provides indicators for evaluating the performance of health services and their impact on the health status of population. Yesterday, we looked at health system performance and we looked at indicators for service delivery, for health manpower, for financing, for health information management, and then for stewardship, and then medicines and health technology, yes, vaccines. So, provide indicators for evaluating performance of health services and their impact on the health status of population. They also provide information for all those who need to take action, those who supply data, and the general public. Any questions, class? So where do we get health data? We can get health data from primary and secondary sources. Principal sources of health data are population and household census prepared and projected by the National Population Commission. Then the Federal Office of Statistics or National Bureau of Statistics. Household censuses produce data on health-related services, such as housing, water supply, toilet facilities, if there's overcrowding, and so on and so forth. Then we also have from vital event register, legal registration, statistical records, and reporting of vital events, such as births, death, marriages, divorces, and so on and so forth. These registrations of vital events are available at appropriate state authorities. Then we're talking about routine health service data, dealing with morbidity and mortality. Those ones we generate in the healthcare sector, immunization, disease treatment, outpatient attendance, admissions, discharges, number of surgeries performed, and so on and so forth. These data are obtained from the records of health services in both public and private health facilities. Any questions, class, with regard to sources of health data? You know all this because you're all health workers. So we're just saying it because it has to be said. So that when we set it in the exam, you say they didn't teach you. So then surveillance data is also important to cover immunization records, disease notification, and indication of disease incidence and prevalence. We also have disease registers for specific morbidity and mortality, like cancer register, sickle cell register, handicapped persons register. Then for budgetary allocations, we're looking at federal and state as well as local government allocations to health sector. We get them from Ministry of Finance and Planning as well as local government authorities. Then community surveys that can be undertaken in collaboration with National Population Commission or Federal Bureau of Statistics, university departments, and NGOs. For a long time, the data we had about HIV/AIDS was through sentinel surveillance. Pregnant women who go for antenatal, and then students who enroll in universities who have to go through medical exam, or the military during their screening for new recruits. HIV test screening is done. So any questions, class? So data from school health services, periodic medical exam, prevalence of skin diseases, data from special national health programs like the rollback malaria when they initiated it, essential drug program, family planning and reproductive health management information that tell us about use of family planning commodities, the different types of family planning methods, and so on and so forth. Other health data could include registers of health institutions and health personnel. In other words, number of intakes into health institutions, training institutions, number that are graduated. Can also have information from the regulatory bodies, Medical and Dental Council of Nigeria, Medical Laboratory Science Council of Nigeria, Pharmacist Council of Nigeria, Nursing and Midwifery Council, and so on and so forth. Optometrist Registration Board, like that. They give us information about manpower situation. So the totality of the above sources of information and other specific and dedicated sources of information, how we handle them, transmit that information and make use of them, make up the National Health Information Management System. So all these data sources, how they are transmitted, handled, and used, make up the National Health Information Management System. So at the primary healthcare level, there are different forms, village health worker forms. If you go to a primary health center, you see wall charts telling you about their immunization activities and other things, outreach programs. Then you have immunization registrars, health form for registration of births and deaths, form for registration of community health activities, family planning booklets, general health facility booklets for recording various diseases that are seen at this PHC. Some of these forms are complex and cannot be accurately completed by the PhD workers. Additionally, the return for the information collected are usually very poor. That's at the PhD level. So let us look at surveillance. Let us look at surveillance. What is surveillance? What is the WHO definition of surveillance? Surveillance is about systematic watchfulness over an area for the occurrence of certain activities of interest. So the WHO defines surveillance as the systematic and ongoing collation, analysis of data, and the timely transmission or dissemination of the information to those who need to know so that necessary action can be taken. Similarly, the Center for Disease Control, US, defined surveillance as the ongoing systematic collection, analysis, and interpretation of health data and are essential to the planning, implementation, and evaluation of public health practice. Are closely integrated with the timely dissemination of that information to those that need to know, because that information will be used by people. So the final link in the surveillance chain is the application of this data for prevention and control of diseases or health problems. So in epidemiological practice, surveillance is very important. Surveillance tells us whether the disease has been adequately controlled. It tells us whether there is a new outbreak. It tells us whether there is a recrudescence of the disease. It tells us whether there is a new disease coming in. Without surveillance, we will not know how much of control we have exercised over a disease. So surveillance information collected and analyzed about clinical diagnosis, laboratory diagnosis, and mortality, as well as other relevant information we need to detect and track disease in terms of who is involved, where did it happen, and when did it happen. So by observing trend in person, place, and time, changes can be observed or anticipated, and appropriate action, including investigation and control, taken. In other words, we should be able to use surveillance data to predict outbreak. That's why syndromic surveillance is also important. Syndromic surveillance is about presentation of cases based on syndromes, signs and symptoms that are not being returned. In other words, the laboratory is seeing more cases of this. The pharmacy is seeing more prescriptions for this particular disease, higher than the normal situation. There are more samples collected for this disease than normal situation. Or pharmacists said we are having people coming with prescription for this, meaning that something might be going wrong. So surveillance system must detect new communicable diseases as well as recognize and track diseases that currently are or have the potential to become of major public health importance. So why do we engage in surveillance activities? What's the rationale for surveillance? The times change rapidly. So weather changes, climatic changes, and so on and so forth. Changes in human movement, mobility, and whatever can bring about transmission of diseases. So rapid changes in current times includes rapidly changing environment for microbes as well as humans. For example, there has been unprecedented population growth accompanied by rapid unplanned urbanization. This has resulted in large increases in urban slums without adequate water and waste management. Additionally, many of the people living in slums are migrants from rural areas with little immunity to urban diseases. So such changes create an excellent environment for communicable disease to thrive. So rapid urbanization combined with lack of vector control in the case of South America has led to increased spread of Aedes mosquito and consequently increased risk of dengue, Zika, and yellow fever epidemics. Another factor that is important at giving rise to surveillance is air travel. Air has become the easiest way of moving from one place to the other, and it's very fast. And air travel results in increased potential for rapid dispersion of infectious diseases to new environment, just as we had in the lecture on what's it called? Travel medicine. Then another one is changes in land use. We want to establish new towns, irrigation projects, and whatever. So we go and clear the forest, deforestation. irrigation of land for agricultural purposes, an increased encroachment of people on forests and woodland areas that have increased the threat from communicable diseases. All those forests have microbes. They have vectors. Now we go and clear and leave them bare. So we expose ourselves by those economic activities. Any questions, class?
No
Civil unrest
questions, sir.
Civil unrest and wars are also part of the reasons for surveillance. During wars, troops and equipment as well as displaced persons are constantly moving from place to place, carrying with them infectious disease organisms and the vectors. And this is usually accompanied by destruction of physical and often economic infrastructure in those areas. Go to Ukraine now. Artillery fire, armored vehicles passing here, bombs and whatever. So, for example, dengue increased in Southeast Asia during the Second World War, immediately post-war period, due to the spread of mosquitoes and different virus strains throughout the region. Wars have also been important in the spread of plague. Wars also spurred widespread migration. Migrants may have no immunity to the diseases that are endemic in the new areas they are going, so they can be infected. But if you are from that community, then you will have some form of immunity. But you're coming from a place where that disease is not known, or those diseases are not known. Going there, you don't have immunity, so you can be infected. They are usually stressed, often physically and emotionally, so their immune status is always compromised. So this combined with crowded makeshift refugee camps may lead to disease epidemics. Natural disasters are also reason for surveillance. Earthquakes, flooding, El Ninos, they are part of the problem. So uses of surveillance data. What do we use surveillance data for? Information that is collected is used in a number of ways. We use surveillance data to evaluate the effectiveness of control and prevention of health service programs. In other words, surveillance data enables us to know whether polio has been controlled, whether there are new cases or old cases. HIV, any communicable diseases. So surveillance enables us to monitor changes in infectious agents, that is trend in developing antimicrobial resistance. It also enables us to carry out planning and allocation of resources within the health system. Because surveillance data will give us information where more emphasis should be laid. It will also enable us to identify high-risk populations or areas to target intervention, then provide valuable archive for disease activity for future reference. Now, we all know that there are two types of surveillance: passive and active surveillance. Passive and active surveillance. So passive surveillance is employed in routine surveillance system for disease control program. In other words, those cases that come to the clinic and report, if they are part of the ones that we have interest in, then we record. It is the process of detecting and reporting data or information on this that bring patients to the health facility. So for passive, patients come to the health facility and then we now detect the cases. For active, we go to the community and search for the cases. So passive surveillance often gathers disease data from all potential reporting healthcare workers. So it could come from the outpatient clinic, laboratory, pharmacy, and so on and so forth. Health authorities do not stimulate reporting by reminding the healthcare workers to report disease, no, providing feedback to the individual health workers. The data on individual patients that are recorded in patient register are used to calculate the number of cases of reportable disease diagnosed by the health facility. So for facility reporting to be successful, primary care providers must be able to recognize the clinical presentation of reportable diseases. If you look at most of our clinical notes, we don't make diagnosis. We just write this symptom, this, then we'll start to write tests or medications. So our notes are scanty and incomplete. So it involves having clear, uniform case definitions available at the peripheral level. Additionally, laboratories need adequate resources to make the required laboratory diagnosis. When you are filling a lab order form, there are places for diagnosis. Most times we don't write. So the diagnosis is also supposed to guide the laboratory scientists or technicians on how to focus more when you are searching for organisms on the slide. So what are the limitations of passive surveillance? There are many weaknesses. In many parts of the world, there are very little access to healthcare facilities. And many people fall ill or die at home without even visiting a health facility. In other words, if you are waiting for the cases to come to the facility, those who do not have access, you cannot see them. Those who patronize alternative medical practitioners, you can't have them. So there are problems of under recognition of diseases, particularly those that are new to an area or those with non-specific symptoms. Most viral infections have non-specific symptoms. So we find it difficult to make a diagnosis. In many parts of the world, the level of laboratory support is also inadequate. We have laboratories in most of our primary health centers, but most of them are not functioning. In River State, all modern primary health centers have laboratories, but most of them are not working. So there are common logistic problems reporting many parts of the world: overworked and underpaid staff, lack of motivation for reporting when no feedback is provided, and a need for further training. Overall, there is considerable variation in the quality of the reporting system amongst countries, reflecting economic, social, and cultural, as well as epidemiological difference. Any question? Let's go to active surveillance. Like I told you, active surveillance means going to the community to look for the cases. The system provides stimulus to healthcare workers in the form of individual feedback or other incentives. It involves active case finding in the health facilities and communities. Often reporting frequency by individual health workers is monitored. Health workers who consistently fail to report or complete the forms incorrectly are provided specific feedback to improve their performance. There may be incentive provided for complete reporting. Active surveillance requires substantially more time and resources and is therefore less commonly used. But when we are talking about polio, we are looking for, there were active cases of active surveillance. Go to the community. Was there any child that had difficult walking, that now find it difficult to move, and so on and so forth? It is more complete than passive surveillance. It is often used if an outbreak has begun or is suspected, to keep close track of the number of cases. So community health workers may be asked to do active surveillance active case finding in the community so as to detect those patients who may not come to the health facility for treatment. So active surveillance was employed in the search for acute plastic paralysis cases among under 15 children as part of the strategy for polio elimination in Nigeria. So community health workers use that active surveillance strategy to visit patent medicine vendors, chemists, traditional health practitioners, bone setters, to find out whether there were cases of AFP that had not come to the hospital so that they can trace and capture them. Any questions, class? So let us look at the surveillance system in Nigeria.
Hello, sir, before you continue.
Hello, Shaibu.
Yes, before you continue, I have a little question, sir.
Yes.
I want to ask, what will be the difference between the active and passive surveillance?
I thought I said it now. You were not listening. In active surveillance, you go and search for cases in the community, in the clinics. Are you hearing me? We go to the community to ask, like when we are engaged in polio eradication effort, elimination effort, you go from community to community to ask, is there any child that was walking and now has problem walking? You go to chemists, whether they came with a child who could not walk again, patent medicine vendors, traditional healers, and so on and so forth. For passive, you wait for them to bring the people or the people to come to the hospital to complain. But that one is limited because those who don't come to the hospital or the health facility, you will not capture them. That is the passive surveillance. You wait and let them come and make a complaint. And while they are making it, you can capture them. But that is limited because what about those who don't seek orthodox care? Those who think that the body will take care of the sickness. Or let's go to a traditional practitioner or go and buy medicine from a drugstore. So the active surveillance will go to those places and search and ask questions and see those they said are likely to be of interest. But for passive, you just run your normal clinic and then cases that come and report, you capture them in your data. Have I answered your question?
Yes, sir. Thank you very much, sir.
So, disease surveillance system in Nigeria. The DSN, disease surveillance notification system, was instituted in 1986-87 after the outbreak of yellow fever in 19 states then. So there are different forms used under the disease surveillance notification. DSN 001 is the standard reporting form for recording the occurrence of epidemic-prone diseases. Then 002 is monthly routine reporting for all cases. It contains a list of 40. Then the form is completed at the end of every month and forwarded to the ministry as part of routine data. So it comes from the facilities to the local government, the local government to the state to the national level. So let's talk about sentinel surveillance. It operates through 150 then selected sentinel sites. It's used to collect accurate data to make up what might not be available due to underreporting of the DSN system. Then we have vital statistics. Vital statistics are births, death registers, records of marriages, divorce, and so on and so forth, adoptions. Then the hospital returns records, monthly returns from hospitals based on the International Classification of Diseases, the most recent version. And then there are disease programs, HIV, AIDS, trypanosomiasis, guinea worm, all those ones, all those different programs. They have their information system that send in returns. So the National Program Immunization, Polio Surveillance All these ones have their own program information. So this system was established to monitor polio cases and is rendered weekly to determine progress to the elimination of polio within the country. So you render returns. The Family Planning Information Management System. Planned Parenthood Federation is also has information system about commodities they supply to various places, that then the HIV/AIDS surveillance system, disease eradication programs, all these ones have surveillance systems that have been put in place that generate data. We will not talk about USAID because President Trump has stopped USAID funding for programs like HIV/AIDS and other things. Then the IDSR came in. The IDSR came in. That was the brainchild of the African Regional Center for WHO, 1998. Classified diseases into 3 categories for reporting. IDSR 001, diseases that are targeted for elimination and eradication. Then epidemic-prone diseases. And then for IDS 002, and then 003 for other diseases of public health importance that will require routine notification. So what are the problems of information management in Nigeria? Funding is a big problem. Staff shortage, and then material shortage is also a problem. When they get the data, how to transmit it? If they are using paper data, it's another problem, except it's electronic that you capture and transmit using your palm top. So most cases that they use transport, they cannot transmit. They said there's no vehicle, there is no fuel, and whatever. Then inadequate coordination of data management. Different people are generating data, and there's no coordination for all the data. And then if you go to the primary care level, there are so many forms, complexity of forms. And one person is expected to fill diverse number of forms. And most times they don't know how to fill them well, or they don't fill them completely. And even the ones that are completed and generated and transmitted, they don't get feedback on what they have sent to as an incentive for them to generate more and transmit. And then there's always backlog on unprocessed data. Data that is generated now might not be processed and given, but stay there for 2 years. And then lack of timely and accurate data for decision making. Then no evidence of use of collected data. These are some of the problems. So any questions, class, about this? Now we'll go to the last lecture, which is about 3 or 4 slides. We extract from another
Yes,
place.
I have a question, sir.
Yes, go ahead.
Yes, please, sir. When you're talking about the IDSR 001 and 002, you said 002 is for epidemic-prone
IDSR.
diseases. The 002, you said for epidemic-prone diseases. I thought it was the other way around. It was 001 that was for epidemic-prone diseases, since that is the one for immediate reporting.
Was supposed to be for diseases that have been earmarked for eradication then, except they have changed it. This lecture has not been updated, but 001 was for diseases that were earmarked for elimination and eradication, like polio, all those ones, measles. But epidemic-prone diseases, they're 002. Yes, Augusta Oluchi.
Thank you, sir. Good evening, sir. Please, I don't understand the sentinel surveillance.
Okay, let me give you an example. Where do you work?
I work in a private hospital.
Okay, do you do HIV screening for pregnant women? when they come for
Yes.
booking.
Yes, sir.
That is a sentinel surveillance. That's a sentinel surveillance. In other words, it is a point. It's not a moving point. All those who come in for that service are screened. Are you hearing me? Sentinel means like sentry, gate man. So at that gate, anybody that passes through will be screened. Do you understand?
Okay. Yes, sir. Thank you,
Are you
sir.
a doctor?
Yes, sir.
Are you a doctor?
Yes,
say?
sir. I am a medical doctor. Yes, sir.
Have you heard of sentinel pile?
Yes, sir.
Where is it? Where do you find it? It's at the exit of the anus. It's as if it's guiding the anus. That is, it's like a sentry guiding that place. So sentinel surveillance is a static position where everybody that comes in through, like all those HIV screening centers, there are sentinel surveillance points for HIV. All right, thank you.
Thank you, sir.
Thank you,
Have
sir.
I answered your question?
Yes, sir. Thank you, sir.
So let's look at task sharing and task shifting. You see, not seeing my screen. Do you see my screen?
Yes,
Yes,
sir.
sir.
Yes,
Yes,
sir.
sir.
Yes,
sir.
Sir, we can see it.
Yes, sir.
Yes, sir.
What are you seeing?
Strategies to deal with the current
Strategies to deal with current crisis.
Strategies to deal with the current crisis.
Like
Continue.
2 or 3 slides, because this your course, they loaded the program with so many small things. Now, what is task shifting and task sharing? Task shifting and task sharing are interventions brought in to solve health manpower shortage in health facilities. Part of the global health workforce challenges were that most countries do not have enough health workforce. And even the few they have, particularly developing countries, the advanced countries that are producing more are even coming to poach and take to their places. So they make the situation worse. We are not producing enough health manpower, but the few we produce, for one reason or the other, they are migrating to Europe, America, Asia, as the case may be. So part of the solutions to health manpower shortage, one of the recommendations is task shifting and task sharing. What do we mean by task shifting? In the health sector, different people do different assignments. However, there are certain assignments that can be done by a lot of people, or people who are not highly skilled. And therefore, such assignments should be shifted to those less skilled people so that the highly skilled people can concentrate on more serious work. That is shifting the task or sharing the task. Give part of this alone to another person. Do you understand the concept?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Now, when I trained in medical school about 40-something years ago, it was doctors that were collecting blood samples from patients and then they were sent to the lab. Now, the lab people collect samples. All infusions were set by doctors. And I remember that when I was doing my pediatric posting, when I found it difficult to get a line for a neonate, one of my matrons, Matron Manuel, she said, "Doctor, let me help." And she will put past the line for me and I will thank her. Meaning that you don't have to be a doctor to set line. Today, most of the community health extension workers, community officers, they are giving drip in the community. Some pharmacies are giving infusion in the pharmacy. So it means that so many people can do that. Why do you bother a doctor to come and pass line? We can shift that to the nurses or other health workers. So the WHO defined task shifting as a rational redistribution of tasks among health workforce teams involving moving specific tasks where appropriate from highly qualified health workers to health workers with shorter training and fewer qualifications. In other words, let us leave the doctor, let the J2 set this drip. Set this drip. The way we have structured our hospitals is such that in UPTH now, deliveries are taken by doctors. So what do the midwives do? Deliveries are taken by doctors in UPTH. So what do the midwives do? About 3 years ago, one of my church members was pregnant and asked me that, as doctor, where will I go and register for this pregnancy? I said, go to Rivers State University teaching of BMH. So she accepted and went there. Booked, attended antenatal. When she went into labor, resident doctors were on strike. The husband took her to the hospital. The midwife said they are not going to attend to her, the doctors were on strike. Well, what will the new midwife be doing to earn salary? You can't take delivery. Do you understand? So if you say a tertiary hospital, only doctors will take delivery, then what are the midwives? Why are you employing midwives there? So that's why the problem is. So you shift the task from the highly qualified health worker to a health worker with shorter training or fewer qualifications. It's an innovative solution to the scarcity of trained specialized health manpower in low-income countries, as it has been found to offer high-quality, cost-effective care to more patients than physician-centered model, where physician does everything. Countries like Brazil, Ethiopia, Pakistan have successfully implemented task shifting model, and they have given them enormous improvement in health status of their populations. So in Pakistan, the government created the Lady Health Worker Cadre in 1994. And by 2005, they had trained up to 100,000 such female community health workers. And these health workers provide essential primary care services in the community. So we have also created the community health workforce. Choose. So they are carrying out a lot of work. Most of the antenatal immunization have been shifted to them. They even run family planning clinics. They take delivery. Delivery that midwives refuse to take in teaching hospitals, they take. So Nigeria trained and deployed CHOs, CHUs, and JCHUs in the primary care setting with variable results. The results are variable because most times they don't go to work. Most times they are not at work. They give one excuse or the other. How will a CHU or CHO take delivery alone for a night shift? No single person can take delivery successfully in the night, even in the daytime. So that is how we have made the place not to work well. In some developed countries, they started training physician assistants. Ghana has such a program. US has. They are used to perform tasks where traditionally undertaken by doctors with remarkable success. Any questions, class? So that is task shifting. What about task sharing? Task sharing is the process for enabling lay or middle level healthcare professionals such as nurses, midwives, clinical officers, and community health workers to provide clinical services and procedures that would otherwise be restricted to higher level cadre safely. It entails systematic delegation of tasks where suitable from highly skilled professionals to less specialized cadre in order to improve efficiency and maximize use of existing human resources for health. So task sharing means some of them do some work, you continue to do. But task shifting, you assign some responsibilities to them, delegate those responsibilities to them. So it is therefore a vital strategy in overcoming shortage of doctors in many countries. Even in well-resourced health systems, task sharing offers a means of providing service more efficient. If you have to pay a doctor 200,000 naira every month to do certain things, and you can pay a CHO 150,000, is it not better? Or 100,000, or a CHU 100,000. So let the doctor that is receiving 300,000 face more serious work. So you can still do the same work for less amount of pay. Task sharing is a vision to create more rational distribution of tasks and responsibility among cadres of health workers to improve access and cost effectiveness. In other words, the big man's work, let us give it to the small person. The small person will do it and take small time. Let the big man face more serious work. Class, are you hearing me? OCC,
Yes, sir.
what is your problem?
Yes, sir.
Yes, sir.
OCC,
Yes, sir.
Yes,
Yes,
what's
sir.
your problem? So what are the benefits of task sharing? It has potential to increase access. They are not likely to overwork the single doctor. Some of his work is being given to other people to do. So they'll create access for more people. It has the potential to free up time for doctors and clinicians to spend on other high-level services. It has the potential to allow you to have more impact without increasing spending on salaries. It can allow the same amount of service to be provided by less salary that is spent. So if you have any questions, ask. If not, we have come to the end of today's lecture. You see, previously we used to have a lecture in health system called Global Health Workforce, Crisis and Challenges. Because it is believed that the global health workforce is short by as much as 15 million health workers of different cadres. So Rosemary, your hand is up, yeah? Let's hear you.
Yes, sir. Good evening, sir.
Yes. Unfortunately, they removed that lecture from the health system lecture and picked just this task shifting and task sharing into it. They put small fragmented things into the program. Go ahead.
Okay, sir. In this tax sharing and tax shifting, in giving the tax shifting, in giving the maybe non-qualified health personnel the work of a qualified personnel, do they teach them the rationale behind it? Or be they do blindly?
I told you that there is shortage of health manpower. That's how I started this talk.
Yes, sir.
And we are not producing enough health workers. Even the few we are producing, some of them are not employed. Those that are employed, foreign countries are coming to take them away. So in the hospitals, we have less people to do more work. So how do we make use of the bad situation? We find out that so many people can do a lot of things that are left to doctors to do. To take blood, to set line, to do this. Nurses are made to dress wound, give injection. So many people can do these things. So if a nurse is overworked, let us take part of her work and give to a nursing assistant. If a doctor is overworked, let us take part of his work and give to a community health officer or a nurse. So now we have found that a lot of people can take blood from patients without harming the patient. A lot of people, no doctor will go to somebody's house to set drip. But a lot of these health workers go from house to house in the community to set drip, meaning that they can set drip in the facility. So why can't we give them that work? Instead of looking for a doctor to come and set drip. Do you understand me?
Yes, sir.
Yeah. Now, why did they train the community health cadre of workers? Because doctors were not sufficient. So they trained nurses to be community health officers at the first instance when Rason Kuti was there. Staff nurse midwife gave them training because they work closest to the doctors. Give them so that they can function as doctors in primary health facility where there are no doctors. Subsequently, they started training assistants for third CHOs, the JCHOs, the CHOs. You require 5 credits to go and study nursing or medicine. You don't require 5 credits to be a CHO, a JCHO. JCHOs come with 2 credits, 1 credit, 3 credits. But if you want to become CHOs, they will have 5 credits. Can be 2 sitting, can be 3 sitting, no wahala. So, because they don't have the requirement to train to be nurse or to be doctor, we can still train them to be something else. Most of the primary health centers today in Nigeria are run by CHOs, CHUs, and JCHUs. You might not find more than one staff nurse midwife in a primary health center. If you find one, fine. If you find two, but the bulk of the people providing all the services are CHUs and CHOs and CHUs and JCHUs. Meaning that they have been trained with some skills. So those skills can be used to assign them jobs so that they can create more access to care for the people in the community. I don't know whether you understand me.
Yes, I understand you.
So that is the thing.
Thank you, sir.
Yes, there are 3 more hands up. Please ask your questions.
Okay, good evening, sir.
Esther, go on now. Esther, David, let's hear you. David.
Good evening, sir. Good evening, sir.
Good evening.
Okay, thank you for the lecture. Just a clarification on
Please raise your voice. Increase the volume of your laptop or whatever device you're using. I'm not hearing you. David, I'm not hearing you.
His network
is anybody
very
hearing
bad.
me?
His network is bad, sir.
Yeah, his network
Yeah,
is bad. We can hear you. His network is bad.
So let somebody else ask question. There are 3 hands that are up.
Hello, good evening, sir. Please, sir, can you hear me?
Esther, I can hear you.
Okay, thank you very much, sir, for the lecture. My question is, how do we manage the issue of jurisdiction when it comes to tax shifting? Because we've seen issues or we've seen situations whereby we have issues between the CHUs, the JCHUs, and the nurses. They go beyond what they are, what the initial plan was for them, and you see them going beyond.
That facility. Hold on. There is somebody in charge of that facility. Every health facility has a head. The head can share the work. Every department has a unit head or a departmental head. You can shift and share the task under you. The important thing is that supervise the people and be sure that they are doing the work the way it should be done. But if some people say they want to kill themselves, the nurses in Nigeria have problems. Nurses in Nigeria have problems. They say they are short. They prepare the roster in an inefficient manner. A nurse will be on duty for 7 days and take 7 days off. While she's off duty, if there's public holiday, she will add to the 7 days off. She didn't work home. So that is the thing. Now, she said, we don't have enough hands. Can we give you somebody to take temperature, pulse, and respiratory rate for you? You say, no, they don't know how to do it. Then you will work and die. You will work and die. There is no doctor today who will be told that, doctor, you are too busy. Let me set this drip for you. And he will say, don't set for me. Let me take this blood for you, blood sample for you. Or let me dress this wound for you. Say, don't try. No, doctor. But nurses will not want you to help them. They will say, you don't know any work. You will spoil their work. So that is the place. So it is the responsibility of the health regulatory authority in the state to bring out a policy of task shifting and task sharing that would define who can be assigned certain responsibilities where the manpower shortage is severe. And in that case, it will be passed down and you will implement it. So that is the thing. There is nobody who went to school and studied science that cannot take temperature.
Hello, sir.
Do you understand? There is nobody who went to school.
Yes, sir.
After all, we taught hypertensive patients how to take their blood pressure. If we teach hypertensive patient, a market woman how to take her blood pressure, why can't somebody who went to school take blood pressure for you? We teach a diabetic patient to prick the thumb, take blood, and test for blood sugar. Why did we teach them that? If we won't allow more educated people, health workers, to do that in the lab for us. Let me tell you something. Most of the laboratories at the primary health center, or even private labs, the people who do the work are not scientists. They are technicians and assistants. Do you agree with me? They are lab technicians and assistants. Look at the pharmacies.
Yes.
Look at the pharmacy shops. Most of the people who are dispensing drugs there, they are pharmacy assistants. They are not trained people. So it means that these things can be done if you train the people. Yes, Osita, what's your name?
Hello, sir. Good evening, sir. Good evening, sir.
Yes.
Yes, my name is Osato. Thank you very much for the lecture. Thank you very much for the lecture, sir. Please, sir, I'm not so comfortable when you go beyond this lecture and like you are insulting the nurses. Yes, I'm not so comfortable when you go beyond this lecture and you are insulting the nurses that they don't want more hands, they don't want to be helped, they will work and die.
Listen to me.
I don't think
Listen
it's a very
to me.
nice
Maybe you are a
statement.
nurse.
I'm not
Hold
comfortable
on.
with it.
You don't have to be comfortable. Let me tell you, so I'm not a small boy. I have worked even in UPTH. When in my Department of Public Health, when the nurses, hold on, stop talking. Stop talking. Will you stop talking or I end the session?
That statement is uncalled for.
Listen to me. Listen to me. They were complaining.
You can go ahead, sir. You don't need to.
Will you listen to me? Nurses were complaining that they don't have enough. Okay. Let us give you choose. You have choose. Let us give you choose to help you with vitals. And they say no, that they don't know how to take it. Who told you they don't know how to take it? Let us give you choose. You are complaining that you have too much work. So you give them part of the work. They rejected. But like I told you, there is no doctor in this class who is so busy and you want to volunteer to go and set IV line for him, he will reject it. So whether you like it or not, maybe you are a nurse. I come from a family of nurses. My wife is a nurse. My elder sister retired as a director of nursing in the state. So you don't know nurses more than me. I have told you how, when I was a house officer, a nurse helped me to set line on neonates. So you don't know nurses more than me. You might be a nurse, but I'm telling you what is on ground. You can get angry, that is your own wahala. Who else has a question to ask? You have not run any health facility. They employ you to work. You have not run any health. You have not managed people. So you don't know the problems of managing people.
Good evening, Prof.
Good evening.
Yeah, thank you very much for this lecture. It has been enlightening in many ways. I just want to ask, with regards to these tax sharing and tax shifting, is understandable in a hospital setting, but the regulation in non-hospital setting as regards people stepping outside of their jurisdiction and safety for members of the community, how can that regulation be achieved?
You see, first and foremost, in the rural areas, we are not there. Health services are limited.
Yes.
Access to healthcare is limited. But nobody wants to die. So if your mother is sick and no hospital is close by, they say there is one nurse somewhere, let us go and call her. She's answering nurse, she's probably not a nurse. She might be a CHU or a JCHU. They will go and call her. She might be somebody who is selling in a patent medicine store. They will go and call them. Don't you know that they call those people in patent medicine doctors?
Yes.
They will come and do the work. Whether the thing is harming or it's not harming.
Okay.
But the issue is that because we are not there, because our coverage alienated the rural people, they will not die. They will get service from quacks. So we can regulate it and make sure that people can be supervised while they do some of those things that we do. I don't know whether I've answered you.
Yes, I think we still, it just shows that we still need to increase our regulation and supervision because we can't do without it.
Those people are not working under regulation. Those people are quacks. They don't have license. Are you hearing me? So yes. The issue is that you and I cannot go and NMA cannot go and close those places except they're operating as hospitals. They are claiming that they are doctors.
Okay.
That is the thing. If they are selling drugs in a drug shop, we can't go and close. It's the Pharmaceutical Council of Nigeria that has, or NAFDAC that has authority over those ones. It's not me as a doctor or NMA. We can't go and close a pharmacy shop. Except somebody is claiming that he's a doctor and is consulting there. Then we can go on enforcement and do something.
Okay. Understood. Thank you, sir. Thank you very much.
Any other question? If there's no other question, thank you very much. When do we have lecture again?
Okay, so sir, we have a lecture with you on Friday from the schedule.
Okay, sorry, I'm going for a wedding on Friday, so I don't know. We'll have to reschedule that lecture for another day. Are you hearing me? Course rep.
Yes, sir.
Are you hearing me?
Yes, sir. I can hear you, sir.
I have a wedding to attend in Bielsa, so I'll be traveling for that wedding. I don't know when I will come back. So,
okay, so
let's find another day for that lecture. Then tomorrow, Thursday, I have lecture with PhD class. So we can't have it tomorrow. It has to be sometime, maybe Monday or Tuesday.
It's all right, sir. I'll work with you and the IT people to schedule another class, sir. It's noted.
All right. Thank you very much.
Thank you, sir.
Thank you,
Thank you
sir.
so much.
All right. Good night.
Thank you very much.
Sir.
Thank you, doctor.
Thank you very much.
Thank you.
Thank you,
Prof.
Prof. Enjoy your
Lecture.
weekend.
Have a blessed weekend, sir.
Thank you, sir. We appreciate it.
Sir. Have a blessed weekend.
Thank you, doctor. Not 5 doctors again, no.
But that thing is correct now. Now I sit in the hospital.
Tuesday. Let's go for Owambe.
Class.
Sir.
Hello.
Sir.
You see, there is somebody who is exhibiting ignorance. That was Sato, whoever she is. She's taking it personal. I have nothing to share with you, Sato.
You are very correct, sir.
Be careful of the way you talk to me. I'm not your mate. I am your teacher. Are you hearing me? I am your teacher. So respect yourself.
You're very correct.
I don't know who handle her. We tender our apology on our behalf, sir.
I graduated from medical in 1981.
Yes.
I'm sure you were then.
Yeah, please.
She was not
apologies, sir. Apologies on her behalf.
She was showing too much of emotion.
Sorry, sir. Hold on. Let it
So when I
talk.
tell you something,
talk, please.
you listen and shut your mouth. I have told you my wife is a nurse. My elder sister retired as a director of nursing. Who are you?
Period. Please forgive her.
And they share their problems. And we want to solve them. And they don't want it. I told you, if a doctor is told, doctor, can I set this line for you? Which doctor will refuse amongst you?
No
if he's busy. But the nurses will refuse. And you say I'm insulting nurses. What do you mean by insult? Say they have
Very
cases.
sorry, sir. That's their habit.
And
Did
the
I say not
nurses, they know how to write
comprehensive
reports.
of hypothesis?
They know how to write volumes of reports.
Which one is volumes of reports?
Sorry, sir.
Sir, please forgive her.
Sir, welcome to Bayelsa, sir.
Forgive her, sir.
Will you not invite us with Prof to Bayelsa?
Yes, Prof, come to Bayelsa, please.
Everybody
With his
go.
students. With his students.
Sorry,
You said with his students.
my daughter is in Yenegua. She's a senior lecturer at FMC, Federal University of Tweke. So I'll stay with her. Don't bother yourself.
Wow, Prof, congratulations, sir.
Welcome to Bayelsa, sir.
Sir, congratulations, sir.
Thank you very much.
Thank you so much, Prof. Thank you for today's
Have a
lecture.
safe trip, sir, when you go. Bye-bye.
Have a blessed weekend, Prof.
Thank you.
Have a blessed weekend, sir. Sir, we love you.
Have a great weekend, sir.
We love you, Prof.
Thank you, sir. We appreciate your teaching. Very, very interesting.